Sir, we're in live, sir.
Fine. Very good evening to everybody. I would like to welcome on behalf of Hetero Healthcare Limited to those who have attended today scientific evening. And this is the small endeavor towards the scientific support and scientific activities. As a Hetero, as an organization, we are having the more than 22 years of expertise in the pharmaceuticals. The company amongst the world's largest pharmaceutical manufacturer of API, and we are supplying more than 40% of ARB drugs in the world. Hetero having 25 plus manufacturing state-of-the-art center and is present more than 120 countries with 20,000 plus employees. With more than 200 plus product in portfolio, we are the largest privately owned company today in India. In sector of pharmaceuticals, especially. Hetero Research Foundation started in 1995, and the leading the way through the research and development. We are today the leading in many fields like generic formulations, difficult to make the complex API molecules, and novel drug discovery, apart from that biosimilars generics. I will not take much of the time. Once again, I will like to thank all those who are today joining us with these scientific activities. We have today, we are in fact privileged to having Dr. Sudipto Ghosh as a moderator, program moderator today. Under the guidance of Dr. Ghosh, we have a very good team, and we are having the two topics. We have with us Dr. Shashwat Chachardi and Dr. Pradeep Poddar. As a moderator, Dr. Sudipto Ghosh, he is the senior most leading gastroenterologist in the city, having more than 27 years of experience and expertise in the gastroenterologist practice, clinical practice. Dr. Ghosh has done his MD and then pursued his MRCP from UK. Currently, he is the senior consultant in AMRI Salt Lake. Apart from that, he is associated with Apex Institute of Medical Science and Fortis Hospital, Calcutta. I will like to hand over the entire program to Dr. Sudipto Ghosh to take forward, introduce our speakers, and moderate the entire session. So, sir, over to you.
Thank you. Thank you. Good evening. Good evening, everyone. Am I audible?
Yes, sir. Very much, sir. Very good evening, sir.
Yeah, but I cannot see myself in the screen. It's a different screen there. Yeah.
It's a slides of yours.
Yeah.
Can we have another slide?
Yeah. Good evening, everyone. Thank you, Saket, and the team of Hetero Healthcare for giving us this opportunity for this webinar. Without wasting time, I would like to start the webinar. Our first speaker is Dr. Shashwat Chatterjee. He has completed his MD from Kolkata Medical College. He was an alumnus of NRS Medical College. He subsequently did his DM from IPGMER in hepatology. And then he has been working as a gastroenterologist in CMRI Hospital, a bright gastroenterologist of the Young Brigade. So Shashwat will be speaking on clinical experience of Midodrine as a vasoconstrictor in hepatorenal and ascites, refractory ascites syndrome. Over to Shashwat.
Thank you, sir. Thank you for this kind introduction. And today evening, I am going to speak about the clinical experience of using Midodrine as a vasoconstrictor in hepatorenal syndrome and in certain situations with ascites. Moving on, what we have here is a new molecule. We first need to look at what it was indicated for initially. It was indicated for people who were having orthostatic hypotension. Now, how did a molecule which was otherwise to be used in cardiology ended up being used in liver diseases? The initial idea came because a lot of patients with cirrhosis, especially with decompensated cirrhosis, were found to have a relatively low blood pressure, which is normal in these people, but not normal in other people. Now, using these molecules and certain ideas by brilliant workers in the field led us to where we are today. So, first of all, I will be speaking about ascites. Well, in late stages of cirrhosis, that is in decompensated cirrhosis, ascites is pretty common. It is the most common decompensation at presentation across cirrhotic patients, irrespective of the etiology. And also, it is the most common decompensation of cirrhosis overall among all the possible decompensations of cirrhosis. It is usually considered irreversible if in very advanced stages. In earlier stages, the usual treatment protocols such as dietary fluid and salt restrictions and adequate diuretic use tends to help a subset of these patients. Well, if we look at why patients in India get cirrhosis, the principal reasons are still alcoholic liver diseases, chronic hepatitis B, chronic hepatitis C, and NASH or non-alcoholic steatohepatitis is gradually picking up and is expected to become the third most common or the second most common cause of liver transplantation of patients who decompensated cirrhosis who undergo liver transplantation. Moving on, we all know about the natural history of cirrhosis. If we develop a cirrhosis today, it's not that we develop a decompensation tomorrow. There is a time lag in between. The typical natural history, as described in hepatitis C, is a classic example of a long drawn process whereby at least 2 to 3 decades pass before any noticeable changes physically or biochemically tend to occur unless we investigate the patient earlier for any other reason. How do we classify cirrhosis? Broadly speaking, we classify it into two things. Either it is a compensated cirrhosis or it is a decompensated cirrhosis. What do we mean when we say that the cirrhosis is decompensated? Well, one, the patient needs to have structural and functional impairment in the liver. It is expected to occur in patients with cirrhosis and needs to have at least one of the four problems, the noted below. They need to have either ascites or variceal bleed or jaundice or hepatic encephalopathy. Among all these causes, among all these four types of possible causes of decompensation of cirrhosis, there is no definite fifth. However, recently researchers are speaking about epistaxis as another possible decompensation of cirrhosis. It is not yet classically described as a decompensation as yet. So, I will limit decompensations to all these four, ascites being the commonest, jaundice and hepatic encephalopathy being one of the more advanced features of cirrhosis and usually have a very poorer prognosis. That is only if we exclude obstructive causes of cirrhosis such as PSC or PBC. Well, how do we classify cirrhosis? Cirrhosis is classified in several ways depending on the portal hypertension and depending on the natural history. This classification helps us to understand that all cirrhotic patients do not have the same risk of death. All cirrhotic patients do not have the same risk of progression of the disease. However, as the disease progresses from one stage to other, the mortality progressively rises from only 1% in patients who have no esophageal varices per year to about 3.4% even when a patient has compensated cirrhosis but esophageal varices or gastroesophageal varices or gastric varices appear. Now, it jumps to about 20% a year when the patient has developed ascites and when the patient has another GI bleed or multiple decompensations, the chance of mortality is about 57% per year. Therefore, this leads us to this question: what more do we need to look for in a patient with decompensated cirrhosis? What should we bother about? What should the patient and their relatives be on watch out for? And when should we admit the patient? Answering this question is this slide. whereby we also need to watch out for liver SOLs or portal venous thrombosis on routine screening ultrasonographies at the bare minimum, hepatocellular carcinomas, spontaneous bacterial peritonitis, portopulmonary or portopulmonary hypertension or hepatopulmonary syndrome. My apologies. A frequently overlooked component of cirrhotic cardiomyopathy, which becomes terribly important when the patient is scheduled to undergo or is planned to undergo a liver transplantation surgery or any other surgery, even non-GI surgeries in the compensated cirrhosis stage for that matter. Now, if we look into the same thing, the staging of cirrhosis, this is something which has been compressed in one slide. When we have these classic stages of from stage 0 to stage 5, this is what typically tends to occur. However, there is another thing which has been recently described as stage 6 or late decompensations, and there is some stage jumps which we were not familiar with earlier when this concept was initially put forward. That is the concept of acute and chronic liver failure, which does change the prognosis to a great extent. In this talk, I will not be talking mostly about ascites in acute and chronic liver failure, because refractory ascites is more sine qua non for a very advanced decompensated cirrhosis. And all of this we bother about because the chance of death of the patient is quite high. And as the stage increases, the chance of death exponentially rises, sometimes more than twofold from one stage to the next. Moving, why are we bothered about this staging? If a person has got compensated cirrhosis, has got no symptoms, has got almost no esophageal or no esophageal gastroesophageal varices, the median survival is more than a decade. On the other hand, if a person is symptomatic and at the other end of the spectrum has got a decompensated cirrhosis, has got an ascites, the median survival ranges between 2 to 4 years across the studies. And if unfortunately there are events such as which precipitate acute or chronic liver failure, then the risk of death increases exponentially. Why does a portal hypertension patient that is in cirrhosis accumulate ascites? Very simply put, the portal hypertension leads to splanchnic vasodilatation. What does it do? It leads to upregulation of several normally physiologically present mechanisms in the body, which make the body accumulate more sodium and more fluid. And this leads to the vicious cycle of ascites formation. There are several theories. There are several ways in which it forms. Suffice to say, the end result remains the same, that ascites is a common decompensation of cirrhosis across the board. What happens is, initially, we might have an ascites. Later on, diuretics don't seem to work. And even later on, the patient may develop hepatorenal syndrome. We dread it because the median survival in hepatorenal syndrome ranges from weeks to months. That is what has been typically described. So, this is correlated with the hepatic venous pressure gradient or the HVPG. More the HVPG, more problems seem to occur. 10 seems to be the cutoff, which we usually do not have any ascites. Above 20, the prognosis is very, very poor. And it all depends on the grade of splanchnic vasodilatation and the grade of vasoconstriction in the renal circulation and in some parts of the systemic circulation that we get to see. Well, how do we approach for the treatment for ascites? We have to look at the SAG of the ascites. Like when we look at anemia, we have to look at what is the MCV, what is the MCH, and what is the reticulocyte count. Similarly, in ascites, it all depends on SAG. If the SAG is high SAG, it means portal hypertension. So what is high SAG? It is typically described as more than or equal to 1.1. So we need to look at the possible causes. Is the patient consuming alcohol? Is the patient having a treatable cause, such as hepatitis B or hepatitis C? Is the patient taking too much salt in his or her diet? We need to look into it. No ascites with a high SAG should be managed. Should be managed with only diuretics. Dietary salt restrictions and water restrictions for it are a must. We also need to identify precipitating factors. Why did this patient develop ascites suddenly or develop ascites again? Whether the patient has got a bacterial peritonitis, a new onset GI bleed, some medicines that should not have been taken by the patient, whether the patient is taking too much salt or too much water without understanding, whether he is taking the adequate doses of diuretics is a must. On the other hand, we have low sag ascites. I will skip this because it is now almost never found in cirrhosis and is not characteristic for portal hypertension. Dietary intake of salt should be a sodium less than 2 grams per day, that is equal to less than 5.2 grams of table salt per day. And this alone has been shown to eliminate ascites in about 1 out of 10 people. Urinary sodium can be used. It is not routinely used, but it can be used in certain situations, especially when dietary salt restriction is in question, or we need to look into whether the adequacy of sample which has been collected for 24-hour urine for any reason, or we need to look into whether there has been a negative sodium balance, or if we are questioning the efficacy of diuretic treatment when there is no response even after 3 to 5 days of diuretic use. Moving on to refractory ascites. The International Ascites Club has defined refractory ascites in very clear-cut statements. The statements has two main arms. It may either be diuretic resistant, that is, it cannot be mobilized despite optimum use of diuretics and optimum salt restriction and fluid restriction, and something which is diuretic intractable because the patient cannot be given the maximum tolerated doses because it is clearly not good enough, since side effects or adverse drug reactions from the diuretics come into play. So either it has to accumulate very early, reaccumulate very early, or it cannot be mobilized properly. Next is why we have to stop using maximal doses of diuretics in most patients. Maximal doses being defined as 160 milligrams of furosemide with 400 milligram of spironolactone over a 24-hour period. The mean weight loss is either not good enough, or there is a early reappearance within 4 weeks of a tense or a grade 2 ascites, or development of either renal dysfunction or hepatic encephalopathy or symptomatic or asymptomatic hyponatremia, or changes in electrolyte levels in potassium, or other incapacitating symptoms such as muscle cramps, which are very, very rarely necessary, but sometimes become unavoidable. Also, it is seen that some people really don't have any significant weight loss despite using maximal dose of diuretics. How do we know that the weight loss is adequate? Well, it is a weight loss of less than 0.8 kg over 4 days makes us think of lack of response. On the other hand, a weight loss of more than 2 kgs over 5 days makes us think that the response is adequate, provided diuretic-induced complications have not occurred. How do we manage refractory ascites? Well, sometimes we need to go to the entire length of the spectrum. It includes medical treatment, large volume paracentesis, transjugular intrahepatic portosystemic shunts, liver transplant, sometimes palliative treatment, and sometimes off-label treatment. So as an initial step, we need to look into the drug chart of the patient. We need to look into what the patient is taking and what the patient should not be taking, or what the patient should be taking and is not taking. Once that is done, we need to look into dietary salt and diuretics, whether the salt restriction is adequate or not. Simple things, a loss of taste in a cirrhotic patient can make him take a couple of packets of any potato chips in a day. Well, when we go and ask about it, look into it, then we get to understand this is a simple thing that we needed to stop in the first place. An important thing to note here is we often prescribe patients or cirrhotic patients diet, or our dietitians prescribe diet. I have had on several occasions found that patients and their relatives misinterpret dietary salt restriction as a bland diet devoid of all other spices. We often need to look into that so that the patient retains some of the taste that they need to palate their food. Moving on, we continue diuretics till urinary sodium is sufficiently low. Once it falls below 30 millimole, we consider stopping it or rather reducing it in most situations. In a next step, beta blockers and ascites. Well, the data is conflicting, but if the patient has bled in the recent past, beta blockers need to be used only and only when nothing else is working. We really need to consider stopping beta blockers, and we need to use Baveno 6 consensus as to when beta blockers should be reduced or temporarily discontinued. It is either a systolic blood pressure which is sustained to be below 90 millimeter of mercury, or a creatinine level, absolute level more than 1.5 milligram per deciliter, or a sodium level below 130 millimole per liter. Then we can consider temporarily reducing or discontinuing the dose of these beta blockers. Where does oral midodrine come in? Well, it was originally worked out as a good molecule, as an alpha agonist to increase overall blood pressure. It is used in patients who have hypotension. This is commonly present in patients who have diuretic-resistant ascites and who do not respond otherwise. Therefore, it is a good molecule for refractory ascites. To start with, we can start with 5 milligram orally as a thrice daily dose, even though midodrine or the active metabolite of midodrine has a half-life of about 4 hours. This seems to work quite well. And when it is tolerated, we increase it by increments of 2.5 milligram per dose to achieve a mean arterial pressure more than 82 millimeter mercury. Beyond that, it's really not that helpful as far as a high orthostatic hypotension symptoms are concerned. Well, as I just considered, it is metabolized by liver to midodrine. It is bioavailable to the tune of 93%. It is water soluble. To an extent, it is soluble in ethanol. It has a plasma half-life of less than half an hour, and it is eliminated marginally by renal secretion as the principal molecule, and as the metabolite, most of it has got renal secretion. How does it work? Well, it works by alpha agonistic activity, whereby it ultimately leads to slackening vasoconstriction, improvement in systemic circulation, improvement in renal perfusion, and thereby improvement in renal water excretion, helping in controlling of ascites. The starting dose is 5 milligram TDS. If you are more skeptical, we can begin with 2.5 milligram TDS, but 5 milligram TDS is what has been recommended. The increments are by 2.5 milligram per dose in order to achieve a systolic blood pressure increase of about 10 to 15 millimeters of mercury. Must be taken during the day, because otherwise the patient is going to have to wake up a lot of times during the night just to pass urine. Should ideally be taken a couple of hours after awakening, about 4, and the last dose being taken about 3 to 4 hours before bedtime. We need to remember that even when the patient is not walking around, even at rest, the patient will have an element of hypertension, because that is how this drug has been designed. So nocturnal hypertension should be watched out for. There is sufficient data. Well, it improves systemic and renal hemodynamics. Meta-analysis has proved this to this effect. There are a total of 10 trials with midodrine. A total of more than 460 patients were included. Data from only 5 on response rates was available from 5 trials. The mean plasma renal activity was reduced, and it is a less costly alternative to repeated bouts of large volume paracentesis, which is tried to be reduced by addition of midodrine. In most studies and in most patients, we cannot totally avoid periodic large volume paracentesis. However, what we can achieve is reduce the frequency. Typically, we can reduce the frequency over a 4-week period by about 25 to 30% when midodrine is given in optimally tolerated doses. And it has been found to be useful when combined with standard medical treatment alone. Midodrine doses, the minimum recommended doses come to around 15 milligram per day or 5 milligram TDS, and 24-hour urinary volume increases, thereby the total water deficit from the body increases, the body weight reduces as a result, and because ascites is accumulating in a less degree, the patient tends to have lesser symptoms of early satiety, the quality of life improves, the hospitalizations reduce, large volume paracentesis reduces in frequency, and undoubtedly, as far as the data goes, it is safe for most patients. Randomized control trials, pilot trial by Dr. Virendra Singh has shown that over a period of time, low sodium diet, diuretics, then midodrine work better in refractory ascites. There is significant increase in urine volume, urinary sodium excretion, mean arterial pressure, decrease in plasma renal activity. Along with this, there is decrease in cardiac output and increase in vascular resistance. Therefore, it was deemed and found to be superior. The mortality rate at 90 days was also lower in the midodrine group than in the standard medical treatment alone arm. Therefore, it is a molecule which should be considered in patients who have refractory ascites. On short-term use, it has been found to be superior. We have data for 3 months. We have data for 365 days. The mortality benefit is very clearly present. On shorter use, mean arterial pressure, heart rate benefits, benefits in cardiac index, and systemic vascular resistance have already been demonstrated. And in refractory ascites, response rate for refractory ascites is found in few patients. Like I said, partial response is seen in most patients. Absence of response is relatively uncommon, but it is not that all people respond equally. And therefore, there is no hepatic or renal dysfunction by the use of this molecule with standard medical treatment. Plasma renin activity reduces, urine output improves, urinary sodium content increases, systemic vascular resistance increases, the cardiac output decreases, the symptoms of hypotension reduce, the mean arterial pressure increases. Rifaximin has also been tried along with midodrine for refractory ascites, and the conclusions say that used alone or used with rifaximin, it is preferable that you use midodrine with the standard medical treatment rather than trying to combine it with midodrine alone. And albumin infusions have also been compared with midodrine. The results are better with midodrine arm. It is effective. It is more cost effective. The guidelines also include considering adding it when the first line agents do not work in control of a patient who has refractory ascites in a cirrhotic background. And we should remember that it leads to increase in blood pressure even at night. That is something we should be careful about. We should have a very clear-cut idea that above a mean arterial pressure of 82 millimeter mercury, we need to stop increasing the dose further. 7.5 milligram thrice daily is something that is typically being used. 5 milligrams thrice daily is a good starting dose. It is recommended in guidelines, and it has been used prior to a patient getting a tips inserted or prior to a patient who is awaiting a liver transplant, and it has been shown to have its own benefits. For hepatorenal syndrome, we all know the definition. We have to have a definite rise in creatinine values above baseline for a particular period of time. There is a doubling time. Other causes of acute kidney injury in cirrhosis need to be excluded. Chronic kidney disease underlying in a cirrhotic patient needs to be excluded. Vasoconstrictors do work once the criteria are fulfilled. We all know the mortality. The pathophysiology is can be thought of as an accelerated version, or a version, or the same things occurring as that occurring in the pathophysiology of ascites, only occurring in a far shorter time window, leading to more physiological changes, leading to more mortality. We need to stop the renal damage, the microvascular dysfunction. And as a general measure, volume expanders have been used, tips have been tried, liver transplant has been done. Sometimes kidney transplants are also required when the patient does not respond that well. Portal hypertension needs to be well controlled. Midodrine used with other vasoconstrictors and albumin very clearly has an effect on this. Consensus statements are available. Renal replacement therapy often needs to be instituted in these patients. TIPS is often considered. Liver transplantation is often the only hope for survival, but till that end, we need to make that patient survive. Therefore, this molecule comes into place. And some general measures such as discontinuation of other diuretics and beta blockers is necessary. Blood transfusions often become necessary. Sepsis needs to be excluded. Antibiotics need to be given. And lactulose doses need to be titrated. So renal vasoconstrictors should be used. And we also know that systemic vasoconstrictors work equally well. As a combination therapy, this molecule, midodrine, has been tried and has been found to be effective. So initially we treat it with either terlipressin or albumin, or octreotide albumin and midodrine combination, or terlipressin or noradrenaline and albumin combination, and we assess the response. If we have a partial response, which is defined by a regression in AKI stage, or we have a complete resolution or no response, depending on that, we often tend to prognosticate these patients. Midodrine is useful. It has been used as a first line. It can be used in several centers. It has been used. It has been tried on an outpatient basis or a daycare basis along with albumin. It has had its own fair share of good side effects. The prognosis is favorable, and therefore, thereby, midodrine has a definite role to play in the management of AKI in cirrhosis, refractory ascites in cirrhosis, and hepatorenal syndromes. I will skip the necessity for the other things. The recommended doses have already been discussed, and thank you for your kind attention.
Thank you, Shashwato. Thank you, Shashwato, for your excellent presentation. I think you have covered the entire area of refractory ascites, hepatorenal syndrome, and the role of midodrine for that. Shall we ask any questions from the audience? If there are any questions coming up in the chat box.
Sir, as you like, sir, if you can take right now or at the end of the entire session, we can.
Yeah, because the two topics are quite different subjects.
Right, sir.
So I thought that, we can finish up the hepatology and then go to the ERCP bit. The one question, Shashwato, which I would like to ask you is how do you think spot urinary sodium is helpful for us? Because often it is very difficult to find out whether we have reached the adequate dose of diuretic or not, or are we dehydrating the patient by increasing the diuretic?
Sir, I will try to answer that question from a very practical point of view. If the urinary spot sodium is more than 90, I get to know for sure that the patient is not doing adequate dietary sodium restriction. If it is less than 32 or 30, I get to know for sure that increasing the dose of diuretics further for natriuresis is not going to be helpful. When we are unsure about the collection of 24-hour urine for, say, in a non-cirrhotic background for 24-hour urinary copper, if we do have our doubt, this thing helps. Other than this, urinary sodium, on a more practical point, really doesn't help me on a day-to-day basis. These are the three situations when I find it to be useful.
Okay. There is a question from Pradeep. When patient is under treatment of midodrine, can we completely discontinue LVP?
No. The answer is a very clear no. For most patients, what is actually achievable is more like a 25 to 30% reduction in the number of large volume paracentesis needed. Meaning, if the person unfortunately required 6 sittings of large volume paracentesis in a 4-week period, what we are practically looking at is the person will need 3 to 4 episodes of large volume paracentesis in the same period. Often it is not avoidable totally. There will be selected patients in whom we can actually reduce it to about 1 or 2 in the 4-week period, if they had, assuming they had a frequency of large volume paracentesis of about 6 episodes in 1 month. But on a phone practical side, it's more like a reduction in the frequency rather than avoidance of large LVP altogether.
Yeah, couple of quick questions before we actually move to Pratik. There is a question, can we prescribe Midodrine in hepatic encephalopathy?
Midodrine does not work well for hepatic encephalopathy. Only for that indication, it is not preferable.
Okay. What are the side effects of Midodrine?
The most common side effect will be a rise in blood pressure leading to palpitations. Sympathetic surge leads to a sweaty skin. Sometimes this vasoconstriction leads to pain abdomen. And if we overshoot the time to give it, I mean to say the person takes it at say 9 p.m., then he is expected to have a very wet night and a very disturbed sleep. These are the most common side effects. Some of them do develop a headache and some of them do develop some chest discomfort. But usually these people do not have myocardial infarctions, though that needs to be ruled out. Sir.
Yeah, and I think that those are some of the effects are due to the hypertension. I think systolic hypertension.
Yes, sir. Systolic hypertension and systemic vasoconstriction, sir.
Systemic vasoconstriction. Excellent. The last question which we have got is, how long can we use Midodrine?
It is given for patients who have refractory ascites. Now, refractory ascites will be absent only when either of 2 events occur. One is a liver transplant, second is we lose the patient. So it's best that the patient undergoes a liver transplant.
Okay, so it can be conceived as a bridge to the next set of therapy.
Absolutely.
If you, yeah. Okay, thank you, Shashwata, very much. I think we will move on to the next speaker, who is Dr. Pratik Poddar. Dr. Pratik Poddar is an MD gold medalist from IPGMER and DM gold medalist in the gastroenterology from LT Medical College, Mumbai. He had numerous national and international publications to his credit, an expert in advanced endoscopy, including ERCP and therapeutic US. He has a special interest for functional GI diseases, including high-resolution manometry and motility disorders. He is currently a consultant at Medica Super Specialty Hospital. Pradeep will be speaking on the role of rectal indomethacin in post-ERCP pancreatitis. Over to Pradeep.
Thank you so much, sir. Thank you, sir. Thank you for the great introduction. I'm very obliged. From all the way from the liver, we move on to the gut, and a very, very important topic close to my heart, which is post-ERCP pancreatitis and how we prevent it. We always say that we should always do no harm, and prevention is always better than cure. So I believe going in the same vein, I think this is what is important is prevention of post-ERCP pancreatitis is as important. So let me start the presentation. So today's topic is role of rectal indomethacin in preventing post-ERCP pancreatitis. Now, let's just touch upon acute pancreatitis just as a refresher. So an inflammatory condition of the pancreas caused by digestive enzymes in autodigestion and causes functional impairment and morphological changes. It can recur and in the long run can give rise to chronic pancreatitis. Now, severe pancreatitis can occur in about 25% of cases of acute pancreatitis, and it's less common. So this data is from the West, but of course in our country also with rising alcoholism, with rising gallbladder disease, with increased weight, we are getting more and more patients of acute pancreatitis, gallstone pancreatitis, as well as alcoholic pancreatitis. In India, the prevalence, right, in 2018, the study came out, the prevalence, you would say, was around 30% above 50 years of age, And again, 50% at 31 to 50 years of age. That is the main chunk of population which is involved. So 45 years of age is the mean age where we're getting a lot of patients of acute pancreatitis. There are a lot of causes. So there are gallstones and alcohol, the most common causes which are there. Of course, malignancies, mucinous tumors, trauma, ischemia, the viral infections, hypercalcemia, hypertriglyceridemias, autoimmune disorders, they can all give rise to pancreatitis. Autoimmune, of course, gives rise to less commonly acute pancreatitis and more commonly a syndrome which is more commonly, which appears to be a cause of pancreatic mass. So it appears as a pancreatic mass, but it actually is autoimmune pancreatitis. And of course, post ERCP remains one chunk of patients where after an intervention, the patient develops pancreatitis. So the diagnostic approach is mainly 2 out of 3. So that is a typical history of pain, an elevated enzymes of amylase or lipase, and an imaging which confirms pancreatitis. So any 2 out of 3 would confirm presence of acute pancreatitis. Now, mild would be when there are no significant local or systemic complications. It would be moderate when there are severe acute or moderately severe when there are local or systemic complications, and there is organ failure for less than 2 days. So there's a transient organ failure. The creatinine rises, the urine output goes down for some time, and then with therapy it improves. So that is moderately severe. If it is severe, you would have persistent organ failure and multiple systemic complications or local complications. Now, there are different definitions. We can have an entire talk on definitions of pancreatitis, definitions, the severity scorings. There are multiple out there. The main thing is organ failure would give rise to a severe pancreatitis, and no organ failure or no local complications would mean it is mild. So the local complications we get usually, you can have an acute necrotic or a peripancreatic fluid collection, or both of them can be present depending on presence of necrosis, as you can see in the picture. You can have a pseudocyst formation when the collection lasts for more than 4 weeks and it develops a kind of a organized wall. It develops into a pseudocyst. And when there is necrosis and necrotic collection, it can wall off, and you can get a walled off necrosis ultimately after about a month. Now, the other local complications, of course, necrotizing pancreatitis, fluid collections, and interstitial pancreatitis can all be present, and they can be described very well both on symptomatology, and of course, imaging helps us in clarifying clearly what kind of complication we are dealing with. So, in necrotizing pancreatitis, you would have necrosis or non-enhancement of more than 30% of the pancreatic parenchyma, and then gradually it necroses and you form a wall and goes on to wall of necrosis. In peripancreatic fluid collection, the fluid collection is mainly homogeneous, so there is no distinct inflammation per se. There is no necrosis. Necrotic tissue is limited, and that is there. And acute fluid collection is there within less than 4 weeks, and beyond that you have a pseudocyst. So this is about the complications. Now, other complications which can happen because of the inflammation and dense inflammation, and there is a hypercoagulability in the splanchnic vessels. So you can have a splenic vein thrombosis, portal vein thrombosis, and of course it can extend into the SMV, and this can actually give rise to gut ischemia in the long run. So we have to be very careful regarding those. It can of course give rise to pseudoaneurysms. So about 2 to 3% of patients can develop pseudoaneurysms. So you can have splenic vein pseudoaneurysms, and they can actually bleed. So if you see a patient of acute pancreatitis who is gradually developing anemia, and within the next week or so, or there's a rapid drop in blood pressure, or the patient has suddenly developing shock, or the patient is having anemia very fast within the next 2 to 3 days, the patient may actually be bleeding into a acute necrotic collection or an acute fluid collection, and the patient might actually be having a pseudoaneurysm. And this edema, dense edema, can actually cause an abdominal compartment syndrome as well. So these are a few complications we must keep in mind. So this is just to stress upon the fact that acute pancreatitis is a problematic situation. Because we're dealing with it, it can give rise to multiple complications, renal failure, ARDS, and this entire cascade can be actually interminable, and it's very difficult to stop it. At this present moment, there is no single drug which is specific for acute pancreatitis which can help us completely reverse it or completely stop it or avoid it altogether. So the most important thing is, when we can't treat it as well, we have to give supportive care. The main thing is to prevent it. So whenever we are doing ERCP, what is ERCP? So ERCP, of course, is something which as a procedure I really love. So in ERCP, we are able to change and affect people's lives radically. You have a bile duct which can have an obstruction because of a stone, or it may be sludge, or it may be it may be a worm. So it can cause obstruction, and we can relieve the obstruction. A patient who is in sepsis or cholangitis can be easily affected, and the patient can be improved when you're putting a stent by an ERCP. The important thing is, earlier in the olden days, we used to have open surgeries for this. We used to exploration of the bile duct was done, but this of course has increased morbidity. There's an increased risk of bile leak, and there are problems of stricture formation. So ERCP is much simpler. It has limited trauma. It has a short recovery time. It is an endoscopic procedure. So the patient goes into sedation. The ERCP is done in 10 minutes, 15 minutes. The patient goes back, and the patient can go for gallbladder surgery after that, and the stent can be removed later on. So it's a procedure which has chances of affecting lives radically. We see patients regularly who come in shock because of cholangitic shock and sepsis, and they improve just by putting a stent and removing the stone and after drainage of the pus. Now, the patient population for ERCP, who have CBD stones or cholangitis, or who have chronic pancreatitis with bile duct strictures, or who have trauma or surgical complications in bile or pancreatic ducts, cirrhosis, also require ERCPs, which cause biliary obstructions, or if there are tumors or cancers of the bile duct or pancreas, which cause problems in drainage of the bile duct or the pancreatic duct, we require ERCP. Now, as with any surgical procedure, as with any interventional procedure, there are risks involved with the ERCP as well. So the important risks, of course, pancreatitis. Of course, there's a chance of ascending cholangitis. Even though we are trying to remove the stone, we can actually introduce bacteria when we are trying to manipulate it. So when you're putting catheters, when you're putting wires, it can actually get infected. They can cause perforations. They can be hemorrhage. Of course, bleeding can happen either post sphincterotomy. It can happen delayed as well. So you can have bleedings. You can have chemical cholecystitis. And of course, there are general complications which can happen. So you have, patient can have cardiopulmonary problems, aspirations, post-anesthetic hypoxia, bleeding, sepsis, drug reactions, and of course, it can result in death as well. So we have to understand ERCP, though a life-saving procedure, has its own set of complications, which we must understand. Now, the patient-related risk factors which are there for increased risk of pancreatitis, the primary complication of post-ERCP is pancreatitis. So the main risk factors associated with an increased risk of pancreatitis, if the patient is young, a female patient, and a suspected sphincterophoidal dysfunction, has a history of recurrent pancreatitis, there is no chronic pancreatitis in that patient, and there has been a history of previous post-ERCP pancreatitis, they definitely increase the risk of post-ERCP pancreatitis. Possibly also, if the patient has no CBD stone and the patient has a normal CBD duct, so we have imaged the patient, we think there's a CBD stone, but actually the patient has a normal CBD and we've done an ERCP, that actually increases the risk of developing post-ERCP pancreatitis possibly. So the patient's bilirubin is normal and there is a periampullary diverticulum which causes some sort of biliary blockage, and that can actually give rise to a pancreatic duct blockage and pancreatitis. Usually a normal CBD diameter or pancreas divisum and an allergy to contrast medium, which is a blood-related allergy, does not usually have any risk of post-ERCP pancreatitis. Now, this is quite a common complication of ERCP. The incidence is around 5 to 15%. So on an average of around 10%, I would say. So out of 10 ERCPs you do, you would end up with one at least having pancreatitis post-ERCP. Now, what are the causes? What is the mechanism? So there are different postulates. So the main thing is when you manipulate the bile duct, there is inflammation, some degree of inflammation which occurs in the pancreatic duct opening as well. And this causes a kind of a mechanical obstruction, or you would say an enzymatic obstruction. So there is an obstruction, partial obstruction to the pancreatic drainage. Some even say that it can actually, there's an activation of enzymes, and this gives rise to a pro-inflammatory cascade and causes cytokine release and causes pancreatitis. Now, the pancreatitis can be limited to the pancreas per se. So you have a local pancreatitis, mild, which resolves maybe in 2 to 3 days. It can actually be a systemic cascade, which can give rise to severe pancreatitis. Of course, the incidence of severe pancreatitis is much lesser. So that is something of a relief. But it ultimately has substantial economic and social impacts. Because a patient who's come for a stone removal, who has a CBD stone, develops, unfortunately, a post-ERCP pancreatitis, and the patient's stay is prolonged. It has a financial burden on the patient. It can actually cause complications. There can be renal failure. It can result in death as well. And this actually has a lot of burden on the patient, a lot of morbidity, mortality problems. And this is a problem. And you always can't predict this pancreatitis in patients who have ERCP. So sometimes it's out of the blue. So we have patients coming to us who is walking in and then develops a pancreatitis after ERCP. And then, I mean, it's difficult for the patient as well as the doctor, both. So I would say the main incidence of post-ERCP pancreatitis, the main risk factors, the criteria, it's a difficult cannulation. And this is the most common procedural risk factor. So if you have a cannulation which takes more than 8 to 10 minutes, you would say the patient has a higher risk of developing post-ERCP pancreatitis. If there's a repeatedly failed cannulation, if there has been a pancreatic sphincterotomy, a pre-cut, who has had more than 2 pancreatic duct injections. So we give contrast to look at the bile duct. Sometimes if you are putting contrast in and you inject into the pancreatic duct, and if it's 2 times or more, in those cases, the chances of post-ERCP pancreatitis are much more. So personally, as when I do my ERCPs, I never inject contrast unless I'm sure I'm in the bile duct. And the incidence of post-ERCP pancreatitis, of course, if there's one, it can happen again. So in India, on all this from the studies, it's around 6%, and in the US centers, it's around 10 to 12%. And the main problem is the duration of hospitalization increases. So around 2 to 5 days in extension of hospitalization because of this. And in the US, around 4 to 11 days of increased hospitalization because of post-ERCP pancreatitis. So it's very, very important for us to be actually preventing this complication rather than dealing with it once it happens. So the main definition that it is an pancreatitis after ERCP by Dr. Peter Cotton, of course, the god of endoscopy, I would say, is a clinical illness with typical pain associated with at least a 3-fold increase in enzymes like acute pancreatitis, with symptoms impressive enough to require admission to hospital for treatment. So the criteria is more or less same and similar to an acute pancreatitis, just that it is associated with a PRCP which was done prior to it. Now, what and how can we prevent it? So the most important thing is using indomethacin suppositories and drugs which are available in the market. Of course, there are other methods as well. So we can use fluid therapies and all that. So let me just touch upon today's topic is mainly using indomethacin suppositories. So what is a suppository? So it is a medicated solid form of a drug which is inserted into the anal canal where they melt and dissolve and they're absorbed. Now this is incorporated into oil bases which melts at that temperature, the rectal temperature, which is mainly a core temperature, and it can also be a water soluble base and which dissolves in mucus secretions. So both are made. Now the indomethacin can be having a PEG base. So when you have a suppository with a PEG base, the main advantage is it is very stable, it is non-irritant and inert, and does not allow any bacterial growth, right? And it provides a very prolonged gradual action, and the suppositories are very clean, and there is no problem in inserting the suppositories when you're inserting it into the anal canal. Now this is a small picture of the rectal blood circulation. So the middle and inferior hemorrhoidal vein drains directly into systemic circulation. It avoids the first pass metabolism, which is the main thing we're trying to avoid. And if a suppository is placed too high, it's absorbed by the upper hemorrhoidal vein, which drains into the portal vein and directly into the liver. So this is something which we're trying to avoid. And it's very important that we place a suppository in the right place. So it should be just into the anus and not very high, because if it goes very high, it will completely defeat the purpose that we did the suppository insertion for. The colon should be clean. So it should be, ideally an enema should be used, but it's not always possible during ERCP, but you can do that. So it should not be placed too high, like I mentioned, to avoid exposure to the liver. And the suppository base is, of course, very important. If it's a PEG base, of course, like I said, there are advantages to a PEG base, and it's very inert and it has a very slow and gradual and a sustained release action. And the motility, of course, can change the drug absorption, and the quantity should be enough. So the most important thing is the quantity should not be so small that it's not absorbed properly. So because it has to be an adequate quantity that can be completely coat the anal rectal mucosa and it can be absorbed easily. And of course, the composition, viscosity, and surface tension also help in absorption. Now, what is indomethacin? Of course, we all know it's a COX inhibitor, a non-steroidal anti-inflammatory drug. And the main thing is it's quite cheap, it's easily administered, and does not have too much of a high risk profile when you're giving as a once dose. So it's a very attractive option for post-ERCP pancreatitis. If you have to give it once, it's hardly any side effects, and you are done with it. So there were multiple studies done for comparison and use of these anti-inflammatory drugs for post-ARC pancreatitis. So there was a study in 2017, and the three drugs which were used were diclofenac, indomethacin, and naproxen. And the primary outcome was development of pancreatitis. And it was shown conclusively that diclofenac and indomethacin both had a lower incidence of post-ARC pancreatitis compared to naproxen. So both were very good actually. In 2018, we had another study, and this was a meta-analysis. And they used a similar criteria, and they did a meta-analysis of all those studies. And around 100 milligrams of rectal indomethacin were used. And they all found that there was a benefit in preventing post-ARCP pancreatitis. The main thing is there was a marked benefit in preventing moderate to severe post-ARCP pancreatitis. So even if the pancreatitis occurred, it was mild in nature, and that is something which is controllable. So it is acceptable if you are at least able to prevent a severe degree of acute pancreatitis. It has a much greater benefit in high-risk patients, and a pre-procedure rectal indomethacin was used. And compared to placebo, the benefit was much higher, and all studies showed a marked benefit. So the risk ratio was around something around 0.56, so around a half reduction in the risk of post-ARC pancreatitis compared to placebo. And the meta-analysis suggests that it prevents post-ARC pancreatitis. It is effective in those with sphincterophotic dyskinesia as well. Of course, there's a controversy regarding that diagnosis as well, but this was there. And it significantly decreases the rate of moderate to severe post-ARC pancreatitis and death. So that is something which is very, very helpful to us. And it should be given, and they concluded in the end that it should be given to all patients without a contraindication prior to ERCP. So there was another meta-analysis which came out in the year 2018. It was published in BMC. And you can see where this was a forest plot of a meta-analysis comparing NSAIDs and placebo. And it was found conclusively in the meta-analysis that there was a significant decrease in risk of post-ARC pancreatitis of NSAIDs as a whole compared to placebo. Now, when they did this comparison when they did diclofenac and indomethacin, both of them showed an improvement, and both of them had a decreased risk of post-ARC pancreatitis. It would be around, the risk was around 0.53 for diclofenac and was around 0.61 for indomethacin. Now, so then they studied the route of administration of the NSAIDs. So there was a rectal route, there was an intramuscular route, oral route, and the intravenous route. And they found the rectal route far exceeded the response compared to any of the other routes. There was some response with the intramuscular route and the oral route as well, but it was very limited compared to the rectal group. So it was a risk ratio of 0.54 compared to a 0.74 for intramuscular and 0.88 for oral. So there was a great benefit. And when we compared with the meta-analysis, compared the time of administration. So people always ask me, when do you give this indomethacin suppository or a diclofenac suppository? They always ask when. So this, of course, is a very controversial topic. Some studies have found conclusive evidence for pre-administration. Some have found conclusive evidence for post-administration. So in this meta-analysis, they found that pre-administration, that means pre-ERCP administration of indomethacin, had a 0.59 incidence of odds of post-ARC pancreatitis, and it was 0.47 post. So the difference is not too much, and so it can be given pre or post, and both showed benefit. Of course, there was no head-to-head trial, so this is something which was there. Again, in 2018, another meta-analysis which showed in 10 RCTs that indomethacin is effective in preventing post-ARC pancreatitis with a risk ratio of 0.63. So it is an ideal option, appealing option, very easy to administer. The patient can come on the table, you can insert the suppository, and then you can start your ERCP, or you can finish off your ERCP and just insert the suppository. And of course, you can do both. So again, in 2020, there was another study, and it was found that the risk of post-ARC pancreatitis was reduced by rectal indomethacin, both in low risk and high risk patients. And it should be administered in all patients unless there's a specific contraindication. If the patient has a NSAID allergy, I think that is the only contraindication. If the patient is having rectal bleeding, or if there's anything else which avoids a rectal suppository, that is the only time which you should not be able to use this, and it's good. So the ESG currently recommends 100 milligrams of diclofenac or indomethacin suppository. They recommend immediately before ERCP, regardless of I mean, if the patient does not have any contraindications, and it's a strong recommendation from them. So it should be used. So if you're trying to prevent against post-CRCP pancreatitis, if the patient does not have any contraindications to NSAIDs, the patient should receive rectal indomethacin or diclofenac 100 milligrams as a suppository. So you can give it pre-procedure and you should make it in a checklist. So in my department, I have made a checklist where the patient receives the suppository as a checklist and the sisters get a checklist, and I confirm every time I start the procedure whether the patient has got the suppository or not. If the patient has a contraindication like an NSAID allergy, of course, fluid therapy has been indicated, but the problem with fluid therapy is we are sometimes dealing with patients who are aged, who have cardiac failure issues, who are very high risk, it's a problem to give high volume of fluid. But in patients who don't have a contraindication to high volume hydration, you should start the activated ringer solution. So ringer lactate at 3 milliliters per kg per hour is a standard you're giving. That comes around to around 150 to 200 milliliters per hour. And this should continue during the ERCP procedure. In patients where there is a pancreatic duct cannulation, I make it a point to always insert a pancreatic stent. If a pancreatic duct cannulation has not happened and there has been a simple procedure, just indomethacin or diclofenac suppository or a fluid therapy is enough to prevent the pancreatitis. Where cannulation has been difficult and there has been a pre-cut, I prefer to put in a pancreatic stent if there has been a pancreatic occlusion. If no pancreatic stent has been placed and the ERCP has been conducted, soon after the ERCP is done, we can give a bolus of fluid around 20 milliliters per kg, and you can continue for 8 hours this fluid therapy of ringer lactate. And this can help in improving the microcirculation of the pancreas and preventing post-ERCP pancreatitis. So to take away, and we would say rectal indomethacin is effective in preventing post-ERCP pancreatitis in high and moderate risk patients. It significantly decreases the rate of moderate to severe post-ERCP pancreatitis and death. So even if the pancreatitis happens, it's mild in nature. There is excellent evidence for it. And even it is even effective in patients with low risk. So even with patients in low risk, it will prevent the pancreatitis. It should be given to all patients without a contraindication. And it's an excellent appealing option, cost effective and safe. So to end, I would say, I think we must do no harm. And I believe prevention is better than cure. So we must use this option effectively to prevent post-ERCP pancreatitis in all our patients where we're doing ERCP. Thank you.
Thank you, Pratik, for an excellent presentation. And it is a topic which is we face every day, in and day out. So it's very important for all clinicians like us who practice ERCP. There are a few questions on the chat box. So we shall start with the chat box questions. The questions from Sandeep. ESG recommends 100 milligram of indomethacin pre-ARCP, but are few still preferred IM route in this case? What would be the better choice and how? I think you have answered these questions.
Yes, exactly.
Yes, you have clearly mentioned that a rectal route is much more preferred rather than other route.
Yes.
And this is an important question from Shubhodip, who said, what would be the ideal time to check amylase lipase if there is pain?
So there is a controversy regarding this because there is something called a post-ERCP hyperamylesemia, which occurs around 20% of patients. So in the initial 6 to 8 hours, you would find patients with increased amylase levels. Now, if a patient, I usually don't go for a test unless until the patient is having pain. If the patient develops pain, a raised amylase level within 2 to 4 hours would point out that the patient is going to develop pancreatitis. So I look for symptoms, and initial 2 to 4 hours, I go for an amylase level. If it is elevated, it means the patient is going to develop pancreatitis, if not yet. If the patient does not have pain and the patient's amylase level is elevated even beyond 6 to 8 hours, then the patient might develop a pancreatitis within the next 24 hours. If the patient develops any pain, then you should think more of in the lines of pancreatitis.
So you check at 6 to 8 hours. That's what.
Yes.
Okay. And the other question is from Mohammed Atik Ahmed. Is indomethacin suppositories can be used in children in other than PEP?
There has been no recommendation regarding children use in pediatric population. We do ERCPs for anyone who is above 10 to 15 kgs. So we can use the adult scope. We don't have the child scope with us. The problem with this is there is no guideline, so it's very difficult to standardize. Of course, the dosage in them would be lower, but in lack of guidelines, we cannot make any recommendation in usage of this drug.
Is there any more questions? I do not think there are any more questions from the chat box. And I think you have dealt with most of the questions in your lecture anyway. So I believe that the take-home message is you should use indomethacin in all cases of post-ERCP to prevent the post-ERCP pancreatitis, unless there is contraindication. Okay. Thank you very much, Pratik, for the nice lecture.
Thank you, sir.
Yeah. And thank you to the team of Hetero Healthcare for organizing such a beautiful discussion where we had both nice speakers and very interesting topics. First one is from hepatology by Dr. Shashwat Chatterjee, and second one is from ERCP, which has been dealt with by Dr. Pratik Poddar. So, good night. I think we should wind up now. Good night.
Yes, sir. Thank you very much, sir. I mean, on behalf of the Hetero, I will definitely like to take this opportunity to thank the wonderful team, Dr. Shashwat Chatterjee, for the excellent and a very well way to elaborate the most of the difficult questions, I mean, doubts in the mind of our community. It was a small effort for the scientific evening. The same times, thanking Dr. Pratik Poddar for such a deliverance. It's such a topic that everybody have lot many questions when we are meeting in the field practically. So it's a stage, it's a platform which has given to sort out most of the queries, most of the doubts in the mind. We are really privileged to have Dr. Sudipto Ghoshar with us as a moderator, taking all the question, all the people's doubts in the same platform and taking the correct way to answer them. Sir, thank you very much for moderating the session in such a way that our small effort makes some sense as a scientific endeavor. It's really an excellent scientific evening. And once again, I will thank the panel for this wonderful deliverance. Apart from that, I would like to thank my backstage IT department, those who have arranged the extremely wonderful way, the smoothless program, as my marketing and PMT team to given us the entire back support. And at the same time, I would like to thank my Vice President Nehru sir for giving us such an opportunity for this scientific evening. Thank you very much, everybody. Thanks a lot.
Good night.
Thank you.
Good night.
Yes, Srinivas, is the live streaming is done?